Hey, good morning. So I'm going to talk about key issues for primary care practice, and I'm going to start by talking about primary care providers' awareness and perspectives on the evidence, particularly from the National Lung Screening Trial, their awareness and perspectives on guidelines, particularly the U.S. Preventive Services Task Force, implementation concerns, current practices for lung cancer screening, and end with some thoughts on ways to facilitate implementation. So most of this presentation is based on a qualitative study that I co-led in New Mexico in 2014. We interviewed 10 family medicine providers, all of whom worked at federally qualified health centers, some in rural, some in urban areas of New Mexico. We asked them about their knowledge, attitudes, and practices regarding lung cancer screening and smoking cessation. To supplement that, I've also done a literature search and was able to identify another half dozen studies also looking at the issue of screening in primary care practice. There were 5 surveys and 1 other qualitative study. So starting with the evidence. When we asked providers about their awareness of the NLST results, unfortunately in New Mexico, the answer was very limited awareness. A survey study in South Carolina showed that 41% of the respondents did believe that low-dose CT screening reduced lung cancer mortality. 18% of general practitioners in a French study thought that LDCT showed efficacy. Because we also wanted to ask our New Mexico providers their perspectives on the results, the fact that they weren't aware of them was a problem. So we actually gave them this sheet, which is from the VA's demonstration project, outlining the absolute mortality benefit as well as the risk of false positives. So their response to the efficacy data was that they perceived that the absolute mortality benefit was small. The South Carolina survey, 76% agreed or strongly agreed that the benefits outweighed the risks. A North Carolina survey from a couple years earlier, though, only 42% rated lung cancer screening as very or moderately effective in reducing lung cancer mortality. They actually perceived lung cancer screening to be less effective than mammography or colorectal cancer screening. So to put this in perspective, the way to really evaluate whether a screening program is working is the number needed to screen to prevent 1 lung cancer death. And when you look at the data, it's clear that lung cancer screening with the number needed to screen of 320 is more effective than screening with mammography or screening for colorectal cancer with sigmoidoscopy. I think the problem is that providers don't realize that when they're being told that there's a screening program that's very effective, that actually the absolute benefit will still be small. The other thing that was commented consistently was that the false positive rate was very high. Fortunately, there are some potential solutions. You've been hearing about lung RADs, which is going to be a standardized way of looking at nodules, which generally is going to raise the threshold for characterizing them as abnormal. One study that retrospectively applied the lung RADs to the NLST data showed that it could reduce the false positive rate by about 15 percentage points, meaning it could reduce the number of tests reported as false positive by either 50 to 75%. The problem is whenever you improve the specificity of tests, there's a trade-off. So there was also a concurrent decrease of about 10 percentage points in sensitivity. We need to see how this applying lung RADs works out prospectively. Another possibility is applying risk calculators to identify the nodules that are most likely to be cancer and thus driving biopsy decisions. Risk calculator based on nodule appearance and size, patient age, gender, family history of lung cancer, as well as presence of lung disease, was shown to have excellent discrimination in being able to distinguish malignancy from benign. About the guidelines. So survey studies basically show that 49 to 86% of survey respondents are aware of the guidelines. The highest level of awareness is knowing that the screening should be targeting heavy smokers based on either current or past smoking. They also recognize that secondhand smoking exposure was not considered sufficient criteria for initiating screening. The lowest awareness, though, was in the areas of how frequently screening should be done and the stopping age. A number of respondents also still thought that chest radiographs were recommended. In terms of perspectives on the evidence behind the guidelines, the New Mexico respondents pointed out that this was only a B rating. It wasn't an A rating. They pointed out that this was a single study with a homogeneous population. As we've seen, more likely to be white, higher socioeconomic status, and so practicing in a minority-majority poor state, the New Mexican providers were concerned about generalizing the results. They also said that the recommendation that could be up to 25 years of annual screening was based on only 7 years of actual study follow-up. In South Carolina, 57% of the respondents strongly or agreed with the statement that the scientific evidence is strong enough to warrant screening guideline. The New Mexico respondents also raised other concerns about the guidelines in general. They pointed out that the task force recommendations in the past have changed over time as well as being very controversial. They talked about breast and prostate cancer particularly. They also talked about taking more of a global view, stepping back and looking at the overall benefits, risks, and costs for all the screening programs that we're expected to implement. So how valid are these concerns? I think there is some reality that there's going to be potential changes to the guidelines. We may see an increase in the screening interval following the negative prevalence screen. We may see risk-based models to target screening as a more efficient strategy. We know that most of the benefit for survival actually accrued to patients in the highest quintiles of risk. The other issue about implementing the task force recommendations, there's a study from over a decade ago that said if you implement, primary care providers would take 7.4 hours a day to implement all the preventive services. This is obviously a worst case scenario, but nonetheless, it does bring up the point, and when a primary care provider is being told to add yet another preventive service, there is a time cost. Other issues, implementation. What I want to do is break this up by different levels at the patient, the provider, system, and societal. So for patient level, providers were concerned about adequate insurance, again, particularly driven in a state like New Mexico. While the Affordable Care Act says there's going to be first dollar coverage for the actual screening test, there's concerns about what are the out-of-pocket costs going to be for all the downstream diagnostic testing and treatment. They raised issues about harms from the psychological stress of screening from false positive tests, radiation exposure, the risks from invasive diagnostic procedures, as well as issues related to the incidental findings. At the provider level, they found that the algorithm for follow-up could be rather complicated. There were competing demands. Not only are we having to deal with other preventive services, we're also taking care of chronic illnesses and acute problems. There were those who were unconvinced by the evidence. There were those who were skeptical of the guidelines. And there was a lot of uncertainty about what insurance and Medicare would actually be covering. They also said that they weren't being asked about to be screened by their patients, because actually being asked by patients was a strong factor associated with actually ordering screening tests. Not yet really on most patients' radars, at least a couple of years ago. The other issues that they talked about was this having to counsel patients about screening. Again, New Mexico providers said that these are complex issues. How do you explain to someone about abnormal results that don't clearly suggest cancer, but still warrant intensive surveillance? How do you explain to patients about the risk and downstream consequences of what's a really involved screening program? They all agreed that educating patients was important, but they also recognized that providers themselves needed information and education about both the evidence and the guidelines. And the providers would need support for supporting decision-making with the patients, specifically asking for things like implementation toolkits, as well as decision aids. New Mexico, again, providers are particularly concerned about trying to educate patients with low literacy and limited English proficiency. So the issue about cancer screening being a problem, I think, is a real issue. I was part of a study where we did a national survey of patients age 40 and older who had faced a cancer screening decision or been screened in the 2 previous years. And one of the striking findings was about 20 to 30% of these patients said that the screening was not even discussed. They were just presented with the results. For those who actually did have the discussions often failed to adequately inform the patients and to engage them in the discussions. There was often an unbalanced presentation of benefits and harms, neglecting the harms. And patients really had limited knowledge about the cancer screening issue, markedly overestimated the lifetime risk of being diagnosed or dying from a cancer. They also markedly overestimated the accuracy of the diagnostic tests. Patient preferences were not routinely elicited, and most of the time providers just made a recommendation as to whether actually for screening. So I really applaud the fact that the CMS has mandated that in these counseling visits that we really do need to engage patients in shared decision-making, and they're encouraging us to facilitate these by using decision aids. The decision aids and shared decision-making also touches on another common theme for the providers, and that is the issue of malpractice. And so the thought is that engaging patients in shared decision-making, according to one legal opinion, will establish a higher burden of proof for patients attempting to claim that they were not adequately informed of risks or alternatives. Washington State actually has legislation that says if a competent patient signs a written acknowledgement of engaging in shared decision-making with the use of a certified decision aid, then signature constitutes evidence of an informed consent. So what's going to happen is people who get screened and are going to have bad outcomes. There's people who are not going to get screened and are going to have bad outcomes. But at least if we are engaging them in shared decision-making using decision aid, there's going to be some legal protection. The issue is there's also rationales for not even offering to discuss screening. You could argue that if someone isn't eligible based on age and smoking history, you may not need to bring it up. Physicians are also going to make determinations that a patient is not healthy enough, that they can't even tolerate an invasive diagnostic procedure, let alone a lung surgery. There's another school of thought that guidelines are guidelines. They're just suggestions, and that the providers may not be convinced that the benefits outweigh the harms, certainly in their individual practice. Unfortunately, there's not much guidance right now. This is still a murky area. It's rapidly evolving. It's not clear what the standard of care is, and so what you have to be prepared for in court. One legal opinion I got is that basically good documentation is going to be crucial. So lung cancer screening is unique because we're talking about linking a screening test with a behavioral change. And so when we asked our providers in New Mexico about smoking cessation, they said they usually inquire about tobacco use and counsel for cessation, either referring to quit lines or prescribing medications. There is uniform agreement that smoking cessation intervention should be part of a screening program. Smoking cessation in the context of screening has been described as a teachable moment when motivation to quit is enhanced. But there's also good evidence that just screening alone is not going to affect smoking behaviors. There is evidence, though, that abnormal findings may be associated with cessation. A study looking at primary care tobacco cessations in the NLST showed that physicians who assisted and then arranged follow-up for smoking cessation for patients in NLST, that was effective in getting people to quit smoking. The problem was most providers offered less intensive interventions, and that was not effective. The other point is that these patients were in clinical trials of screening, so there's clearly a healthy volunteer effect. The question is, what's going to happen when you try to link this screening and smoking cessation in the real world? And at least data from the VA demonstration sites suggests there could be a problem with this. A lot of misconceptions about screening. Some patients actually thought that screening itself would protect them against lung cancer. And then the other theme that came out was the idea of the lucky smokers. They got screened because they had a heavy smoking history, they were at risk, but because their CT scan was negative, they were lucky, they didn't have to quit smoking. And this is clearly an important research agenda, and the NCI has just evaluated, it's now about to fund grants, looking at this issue of smoking cessation and screening in community practice. At the system level for implementation, one of the requests was that the healthcare system helps physicians be able to identify available centers. And what was kind of sobering was in New Mexico, there's a lot of comment that actually the state itself may lack the infrastructure to support high-quality screening programs. And so a lot of the guidelines allude to the need to have a good screening program, but what I particularly appreciated in the American Cancer Society recommendations, they made this pretty explicit. So if you had a program, fine, screen. But if the patient that you have is unwilling or unable to travel to a high-volume, high-quality screening and treatment center, screening is not recommended. The other thing providers talked about for their healthcare system is make sure they've got good support from the electronic health record. New Mexico providers also raised some issues at the societal level, ethical issues such as health equity. They argued that the latest advances should be offered to underserved communities, but on the other side, some argued that it's actually unethical to screen patients if they couldn't afford the follow-up care. Some argued that it was unfair to use societal resources such that non-smokers ended up paying to screen smokers. Another issue at the societal level is economic. Across a number of the studies, there's concern about whether lung cancer screening is actually cost effective. In New Mexico, again, there was thoughts that it's more appropriate to allocate resources towards younger populations, that rather than supporting screening, we should be supporting interventions that will target smoking cessation and prevention. What are current practices for lung cancer screening? In New Mexico, we were hearing that some of the providers were ordering chest radiographs. None of the providers were ordering CT scans, and not only as individual providers, but actually no one at the clinics they worked at were ordering screenings. South Carolina, the survey study, 73% reported discussing low-dose CT screening. However, of those, 59% said that in the last year, they had actually referred only 0 or 1 patient, and many were still recommending screening with chest radiographs. A Texas study of primary care providers attending medical conferences, 56% of them said that they were planning to offer screening, but less than half of them said that they were able to refer patients either to a high-quality screening program to be able to routinely identify eligible patients or engage them in shared decision-making. And only 10% of the subjects said there was a well-functioning lung cancer screening program in their practice. North Carolina data suggests that more providers back in 2013 were offering chest radiographs compared to CT. So what are things we could do to facilitate implementation? I think one of the points is clarifying primary care providers' roles. So as a primary care provider, I know that I should be helping identify appropriate patients, specifically looking at the issue of comorbidity, life expectancy. Is this someone who's going to be healthy enough to tolerate the diagnostic procedures as well as treatments? But we're going to need some guidance. There are other high-risk groups that are being identified and we're being told to offer screening. I now live in Iowa. Radon is a big problem. I'm not sure what I'm supposed to do with that. We also have seen guidelines from NCCN and the American Cancer Society saying that primary care providers should now start offering lung cancer screening to survivors of tobacco-related head and neck cancers. I'm going to need guidance in selecting these patients and knowing what information that I can provide them, because clearly NLST results are not going to be applicable. I think we have an important role in ensuring that patients achieve shared decision-making. Decision support tools are going to be necessary both to educate providers and patients. But the reality is, even though everyone agrees that shared decision-making is a good thing, we have not been trained in that. People are not comfortable or skilled in shared decision-making. And so one of the things we're going to have to think about is we might want to have designated patient navigators who can be trained to be able to deliver consistent, high-quality shared decision-making. We'll also be responsible for arranging follow-ups. That's easy if they basically have a normal CT scan, we order it again the next year. But when it gets complicated, abnormalities that are going to require surveillance imaging or actually referrals for invasive diagnostic procedures, we're going to need some guidance from our radiology colleagues and pulmonology colleagues. There are expectations of the healthcare system. Electronic health record support, as I said, we need to be able to efficiently identify eligible patients. We're comfortable the electronic health record can tell us how old the patient is. We don't have a lot of confidence that they accurately can capture smoking histories. We also, because of CMS expectations on writing documentation for notes, for orders, we need to have templates. We can't be having to write things down every time. One of the things that will clearly make a difference is if this becomes a performance measure. If healthcare institutions tell us that they are going to expect us to do this and then also provide resources as well as malpractice support, that's going to be influential. And ideally, whatever we do should be minimizing the financial burdens on our patients. So I think overall, my perspective is that for primary care providers really to embrace lung cancer screening, we need to have confidence that it can be safely, efficiently, and effectively implemented. We want to know that our patients have access to high volume, high quality screening programs, that we have access to effective smoking cessation programs. And we're also looking to see guidelines evolving. We want to see them looking closely how the new data affects intervals, age to stop screening, looking at better ways of targeting high-risk smokers, making sure that we're implementing strategies to reduce false positive. We also want population-based data. Is it working in the real world? What is the uptake and adherence for screening and surveillance imaging and undergoing invasive diagnostic procedures? What benefits are we seeing in terms of detection of early-stage cancers and receipt of curative treatment? Are we seeing reduced mortality? Are we seeing smoking cessation? And what about the harms? What are the complications going to be from diagnostic procedures and treatments? What's going to happen with all these incidental findings? So when I did the survey a couple years ago in New Mexico, most of the providers were basically taking a wait-and-see attitude. I don't think we can do that anymore. Things are moving rapidly, but I think primary care providers really need to be proactive in figuring out how this can work best for themselves and their patients. Thank you.